future randomised trials in TAVI. Bill Toff, who's the PI of the UK TAVI trial.
Thank you very much, Neil, and thanks very much to the Society for the opportunity to present the trial and to put it into the context of some of the other TAVI trials that have happened to date and that are ongoing. So I think there are some lessons in the history of TAVI that are really quite exemplary. It took a long time to move from the original animal work done by Henning Anderson through to the first in man, the first human implant by Alain Cribier in April 2002. That was 13 years. But impressively, the time to put the first patient into a randomized trial to evaluate this technology was only 5 years on from the first human implant. And that's actually pretty unusual. And when you compare it with angioplasty versus coronary surgery, where 20 years later we're still catching up with some important trials, I think it is a good lesson. Also, the fact that we've collected high-quality registry data in advance of these trials has informed their design and informed clinical practice. But the timing of when you do a clinical trial is always a vexed issue. You don't want to be there on the learning curve, showing the technology before it's realized its potential. On the other hand, you do need comparative data to guide practice. And so I think it's a classic example where Buxton's law applies, that it's always, when you're evaluating a new technology, it's always too early for a clinical trial until suddenly it's too late. People have entrenched their practice and you can no longer persuade them to randomize. So I've summarized here all of the randomized trials, past and ongoing in TAVI, and I've grouped them under extreme risk, high risk, and intermediate risk. I've included one which, although, as Professor Adams explained, was non-randomized, it was non-randomized because of the prior data from Partner B. It was inappropriate to randomize these extreme risk patients, but it's in a sense the partner of Partner B. So I won't go through these in any detail because you know the results very well, but in Partner B and the US pivotal extreme risk, we were looking at patients with an expected mortality or serious morbidity in excess of 50%, and the data showed quite clearly that TAVI is superior to conventional therapy with or without balloon valvuloplasty. We then have the high-risk trials, the real exemplar being Partner A with data now out to 3 years, and the US pivotal trial, which high-risk cohort, which we look forward to hearing about at ACC, and these are looking at patients with an expected mortality of greater than 15%. And we know from Partner A that it showed non-inferiority to surgery out to 3 years in the first instance. Clearly, these are still early data before we move to lower risk patients where the surgical data are available for 10 plus years. We mustn't make the presumption that we've shown equivalence until we have the longer term follow-up. But in the meantime, and mindful of Buxton's law, it's probably time to move on to trials of intermediate risk patients. And there are 2 ongoing, Partner 2A and the TAVI trial, both targeting patients with surgical risk, 30-day mortality of 4% or greater, and the UK TAVI trial, in which we don't have a numeric threshold. We let the MDT decide where the right threshold is. Just at the bottom, I've reminded the lessons here. We know that TAVI is superior to medical therapy in extreme risk patients, and we know, at least out to 3 years, that it's non-inferior to surgery in high-risk patients. So to summarize the Partner 2A trial, this is a trial using the Edwards Sapien XT device in patients with an STS score of 4% or greater. The patients are assessed by a heart valve team, and provided they're operable, the consideration is given as to whether they can be offered TAVI by a transfemoral route or a transapical route. And in each arm of the trial, they're randomized 1-to-1 to receive the Sapien XT valve or surgical AVR. Primary endpoint for the trial will be all-cause mortality and major stroke, a composite, at 2 years with a non-inferiority design. And this trial is now fully recruited and in follow-up. The sister trial from Medtronic using the Medtronic core valve, again, patients with a surgical risk at 30 days in excess of 4%, but interestingly also an upper limit, really trying to define an intermediate risk population here by capping the upper limit at 10%. And the design is similar. The patients undergo evaluation by a heart team and a randomized 1-to-1 to the core valve or surgical AVR, and the primary endpoint again is all-cause mortality or major stroke at 2 years. But for both this trial and the Partner 2A trial, follow-up through 5 years is planned and will be essential before people say we have the answer. And even at 5 years, in this intermediate risk cohort, it would be quite inappropriate at 5 years to say we have the whole answer. But clearly practice has to move on, and this will give some guidance. So to turn to the UK TAVI trial, the third trial, we started planning this back in 2007, soon after the first implants in the UK were performed, and it's taken quite a while to come to fruition, but it's evolved with the passage of time in a way that I think is helpful. And to acknowledge the large group of people, this is the collaborative group that put together the trial. It includes strong representation from the Society and also from the British Cardiovascular Intervention Society. It includes 5 high-volume, highly experienced aortic valve surgeons and 5 of the highest volume interventional cardiology TAVI operators. Where do we fit on the spectrum of risk? Well, we've seen this many times before. This is the spectrum of operative risk increasing from left to right, associated with aortic valve replacement by a surgical route. We know that there's so-called C cohort, patients who are too sick for any intervention, the Partner B cohort, the extreme risk cohort, in whom we now know from 2 studies that TAVI is clearly superior to medical therapy. Selection is obviously important, defining that boundary between futility and benefit. Then we have the Partner A population, the high-risk group. And you'll notice that UK TAVI overlaps that a little bit. It probably overlaps that more than a little bit, because currently NICE doesn't approve TAVI for the Partner A population in the UK. It's not funded and it's not approved. These high-risk patients, NICE does not yet accept that the Partner A data are sufficient to show non-inferiority of TAVI compared with surgery. So we will overlap that group, but we will also encompass this intermediate risk group. And the left-hand boundary here, the lower risk threshold, we've not set out to define. We think 4% is probably too high for many patients and rather arbitrary selection. So our philosophy is to let the MDT decide where that left-hand boundary should be, whilst recognizing that there is clearly a territory which is and should remain the preserve of surgical aortic valve replacement. So in terms of our trial design, it's been much influenced by satisfactory 3-year outcome data from Partner A, and also by what we've learned from the registry data. And I've shown here the 30-day mortality from the SCTS database. And if you look at the octogenarian population, these are all comers. This is everybody who had surgery in the UK in the relevant period. And the surgical mortality, on the left here you see isolated AVR, and on the right AVR plus coronary artery surgery. But the mortality is in the range of 6 to 8%. And we know from the TAVI registry, as you've seen data earlier, that current mortality at 30 days in the TAVI population is now stable at around 5 to 6%. The latest data, 2012, 5.3%. And this is all comers in the TAVI registry, the majority of whom are surgical turndowns. So even in this much sicker population with a mean age of 81, logistic Euroscore mean 22, third of them having prior cardiac surgery and almost 10% with renal failure, it looks like it's a reasonable comparison to be making. So the aim of the UK TAVI trial is to assess the clinical effectiveness and the cost utility of TAVI as an alternative to conventional surgery in patients with severe symptomatic aortic stenosis at intermediate or high operative risk. We're looking at a broader spectrum of patients than Partner A. We're overlapping to some extent, but we're certainly going to a much lower risk population as well. If you remember in Partner A, the anticipated surgical mortality had to be 15% or greater with an STS score guide of 10% or greater. We've avoided a numeric threshold for going into this trial, but we anticipated at the outset that we'd be looking at patients with STS scores in the sort of range of TAVI and Partner 2A. But with the inclusion of unselected octogenarians subject to MDT review, clearly the STS scores are going to be much lower. A second important feature of the trial is that it's a generic trial. It's not tied to any individual technology. Provided a TAVI valve has a CE mark and sufficient user experience as judged by the trial steering committee, it will be eligible for inclusion in this trial. In contrast to Partner A, the trial also includes patients requiring revascularization, which is almost half of those receiving TAVI currently and half of those going to surgical valve replacement. And finally, the essence of the trial is that it's pragmatic. We've minimized the exclusion criteria and we let the MDT decide. The balance of risks, obviously, is that compared with surgery, TAVI may offer a less invasive procedure. We've seen it appears to offer a shorter hospital stay and hopefully a lower risk of procedural complications and death. On the other hand, we still have to be cautious about the higher early stroke risk, which was seen early on in Partner A, although the risk appeared to be less, it appeared to be similar to the surgical risk by 3 years. We have some concerns remaining about the significance of paravalvular leak and uncertainty about long-term outcomes. So the key questions are, is TAVI superior with respect to the early quality of life, early recovery, hospital stay and cost? And does it have at least comparable long-term benefit and morbidity and mortality at least as good as surgery? The trial is a prospective multi-centre UK open-label parallel group pragmatic trial of a TAVI strategy versus a surgical strategy. And it uses a non-inferiority design. And using that non-inferiority design, our primary endpoint of all-cause mortality, we took an assumed surgical mortality of 15%, but that's very much a guesstimate because this is at 1 year. Very much a guesstimate because we don't really know who this population is until the MDT has decided. So this will be kept under review. And in order to achieve 90% power, we have a sample size in the first instance of 808 patients, but that will be kept under review by the Data Monitoring Committee, and we may well need to revisit that. The inclusion criteria for the trial are that the patients have to have severe symptomatic aortic stenosis. They have to be aged at least 70 years with at least one other risk factor, but age alone, if the patient is in their 80s, may be a sufficient risk factor subject to the view of the MDT. Both TAVI and AVR have to be both acceptable and feasible options. Participants have to be able and willing to give consent and able and willing to comply with the study requirements. The exclusion criteria kept to a minimum. This is in contrast to the other trials, of which you'll find a list of 30 or 40 exclusion criteria, all with very good justification for an explanatory trial, but in a pragmatic trial, these need to be minimized. So we exclude patients in whom intervention is inappropriate due to comorbidity or frailty, whose life expectancy is less than 1 year, who've had previous valve surgery, or who require revascularization for which it's felt by the MDT that coronary surgery will be the best option. We exclude patients with predominant aortic regurgitation and if they have mitral regurgitation or some other condition requiring concomitant surgery apart from revascularization. This is essentially the summary of the MDT process. The MDT asks sequential questions. Is intervention appropriate? If yes, is surgery feasible? If yes, is the risk high or intermediate, as judged by the MDT? If so, is TAVI a feasible and reasonable alternative? And if so, they go into the consent process for the randomization 1-to-1 TAVI to surgery. The many risk factors that the MDT will consider are listed here, but there's really no prescriptive approach. Randomization, as I've said, will be 1-to-1 surgery to TAVI, and there'll be minimization to balance age dichotomized around 80 years, center, and the presence or absence of coronary disease, which will be revascularized were the patient to go to surgery. The interventions in the control group will be any form of surgical valve replacement apart from sutureless valves, and concomitant revascularization will be performed if appropriate, and that will be pre-decided by the MDT. In the intervention group, it'll be any trial steering committee approved CE mark valve, and currently that includes the core valve Evolute, and all iterations of the Sapien, including Sapien 3. Any access route will be deemed appropriate by the MDT, will be acceptable. Our approach to revascularization in the TAVI arm is that it's discretionary. The MDT and the operator will decide whether and when to do percutaneous coronary intervention. As I've said, the primary endpoint is all-cause mortality at 1 year, and we have a range of secondary outcomes which are listed here. All of the usual cardiovascular outcomes and 1 or 2 composites. This is not an exclusive list. We're looking at quality of life using the Minnesota Living with Heart Failure score as a disease-specific questionnaire, and the Eurocall as a generic quality of life measure. We assess symptoms and functional capacity using the Canadian Cardiovascular Scale, NYHA class, Nottingham Extended Activities of Daily Living score, and a 6-minute walk. And we assess cognitive function using the mini mental state examination. We'll also be looking at procedural success, in-hospital complications, conduction disturbance, a variety of echo measures, and cost utility. These are the assessment points, and just to stress that we too will be going out to 5 years, notwithstanding the primary outcome assessment at 1 year. Current status of the trial is that funding is in place from the Health Technology Assessment Program of the NIHR. We have all the necessary approvals. We're getting local approvals at the moment and setting up sites. Devices will be commissioned by NHS England. The database is in place, and we're planning to recruit our first patient in the next 2 or 3 weeks. Timeline will be to complete enrollment by July 2016, hopefully much sooner, to report 1-year results soon after July 2017, and to complete 5-year follow-up in 2021. Importantly, every site in the UK that currently performs TAVI will be participating. That's 29 sites, or 30 physical sites at the moment. And the unique features, just by way of summary, are that the MDT is deciding eligibility in this trial with no pre-specified risk score, that we will include unselected octogenarians subject to MDT approval, that we're pragmatic, real-world, generic, and focused on a TAVI strategy rather than a particular valve that may be obsolete by the time many other trials report. We're publicly funded, wholly independent, and not the be-all and end-all, but we will have particular strengths in terms of making assessments that are relevant to the UK context. So in summary, these ongoing trials will clarify whether TAVI is a reasonable alternative to surgery in this intermediate and high-risk population, but we must be sure to await the longer-term outcomes before we presume that we have the answer. So in the meantime, we hope that all these patients will be randomized, which is what NICE is recommending should be offered to these patients. Thank you very much.
Thank you, Bill. It's taken a long time to come to the fruition of this trial, but in some ways I think that's a benefit, that I think it's a much better time to be doing this trial than maybe 4 or 5 years ago. David, do you have any comment about this from the...
Just want to make sure I understand. You don't have to have an STS of 4. It's one of these 20-some things. If you have something in your 70 and you have any... Basically, it's an all-comers trial. Basically.
Yeah.
I mean, it almost could just be an all-comers trial. Like, what's the difference in 77 and you had a TIA 10 years ago and you're 80 and you've never had anything? I mean, it's more or less an all-comers trial.
I think we'd say at the moment it isn't an all-comers trial, because I think at the left-hand end of the spectrum, we clearly recognize this is safe surgical territory. The isolated AVR mortality in the data that Stuart presented earlier, 2%, it's not appropriate to be comparing that. So it's not an all-comers trial. I think Staccato learnt lessons from trying to do that too early. But it's an MDT decides who comers trial, and the MDT thinking will evolve undoubtedly over the 3 years of recruitment.
And we've done two other quick points. One was about risk. Like, I still struggle with, like, how do we define extreme risk? We're not very good at this. Partners and let's just stick with extreme risk. We both predicted 50%. In the high-risk partners, they predict 15% mortality. It's 7%. So was that mortality risk 15%, or is the new risk really 7%? So, you know what I mean? So we're really not very good at surgery. Either surgery got better, or we were too chicken about what we estimated the risk at. But one thing's for sure: all these trials to date have sort of shown better outcome. So part of you wants to ask whether we're already doing some of these intermediate risk patients, because in fact we overestimated the risk to begin with. Maybe extreme risk really was high risk.
I think we are, and that's exactly the point about the timing of a trial. We recognize there's already intermediate risk patients coming through and being treated as whatever definition of risk will get them a TAVI funded.
And that's why one question for you was that 15%. That just seems awfully high to me. In the extreme risk, it's 24% 1 year mortality or stroke. Why would an all-comers trial have 15%? It seems like that number is estimated to be pretty high to me.
I think we accept that that number is inexact, potentially. I think there are a couple of reasons. One is that we don't really think this is an all-comers trial. At the southerly end, we think there'll be a boundary between intermediate and low risk that the MDT will decide. At the upper end, we do overlap the partner A population because there's currently a need for further data in that group. So we're somewhere up there. And the 15%, to be honest, was a legacy from when this trial looked a little bit more like partner A. That's how we started. We started this process in 2008, and we haven't actually changed that figure. So I think there's truth in what you say, but little point in us vexing ourselves over the detail because we just can't, at this stage, guesstimate what the MDT will put through. And those unselected octogenarians will make a big difference to the risk scores.
But I think you're right, David. I think in many units this will be an all-comers trial of people over 75 years of age. I really think that's what will... One quick question, Leslie, and quick answer.
One of the strengths of the NHS is our centralised funding and centralised control. Now, we may dispute that, but is NHS England going to say that funding for these patients will only be given if the patients are entered into the trial? It would speed up recruitment.
That is the case, de facto. At the moment, NICE guidelines approve TAVI only for patients who are in the partner B population. Partner A population is not funded and not approved for use in the UK by NICE, or not recommended, shall we say. So NHS England have NICE guidelines currently say that if you're other than high risk, you should only receive TAVI in the context of this trial. NHS England have agreed to fund unlimited, up to 808 devices within the context of the trial for patients who are randomised.
Just one more quickly.
As a trainee, I've worked across many hospitals whereby the MDT decision to go for surgery or TAVI is very variable. So would you be able to make inferences from that MDT decision as to which route to go for?
It's a very important point, and I think one of the nicer things about this trial is you let the MDT decide eligibility rather than pigeonholing them at the outset with boundaries, artificial boundaries like STS scores. At the end of the trial, we'll have detailed baseline characteristics and we'll be able to describe our patient population. We will also keep track of patients who the MDT felt will be appropriate to randomise who didn't go into the trial so that we can confirm the external validity of the trial. And then also we'll be able to compare between centres where, as you say, practice is extremely variable, and try and capture some of the nuance that arises from a different risk assessment by the surgical input, particularly to the MDT.
Bill, thank you very much. Thank you.
Thank you.